Good morning. This is Maddie Mezzi, and I'm delighted to participate and introduce this presentation on dementia and collaborative care. We will be three presenters this morning, and I'm going to let each of us introduce ourselves. As I said, I'm Maddie Mezzi. I'm here at the Hartford Institute for Geriatric Nursing at NYU, and I'm Professor Emerita and Associate Director of the Institute. Yael?
Thanks, Maddie. So this is Yael Zweig. I'm an adult primary care and geriatric nurse practitioner at the NYU School of Medicine at the Pearl Barlow Center for Memory Evaluation and Treatment.
And this is Marianne Giuliante. I'm the Nurse Practitioner Program Manager here at the Hartford Institute for Geriatric Nursing and also an Assistant Adjunct Clinical Professor at NYU.
And you will notice that we will be going back and forth in making this presentation, which we hope you will enjoy hearing each of our voices and our own expertise. This is an online module of the Collaborative New York Geriatric Education Center, and you will see some websites where we say these again at the end of the module, where you can find this material and also other materials on care of older adults. And you will have noticed as you came into this module that you can print any of the slides as a PDF. The CNYGEC is a consortium here in New York of 4 academic partners, and we've been doing the GEC for a very long time. So we're NYU and Columbia University, the GREC at Mount Sinai, and the James J. Peters VA Medical Center. And the GECs are funded by HRSA, and there is more information about all the GECs nationally on the HRSA website. We have some objectives for this module, and so we hope that at the end you will be able to explain the process for diagnosis of dementia by primary care providers in the primary care setting. That is the full focus of this module. That you'll identify the goals of management of dementia in primary care. You'll identify the benefits of a collaborative practice approach, and we're going to talk about that quite a bit in this module. And you'll be able to identify online resources for primary care providers, for patients, and for family. And at the very end, we're going to talk about some of the considerations for hospice.
Okay, thank you, Maddie. I'm going to review a case study with you now. This is Marianne Giuliante. TA is a 76-year-old woman with a medical and surgical history of hypercholesterolemia, hypertension, breast cancer status post-surgery and radiation, and hip replacement who presents for a memory evaluation at the request of her family. She lives at home and is accompanied by her husband, who provides a history. TA began to exhibit changes in memory about 1 month ago, approximately 2 years after her hip replacement surgery. She began repeating herself, misplacing items, and had difficulty remembering to take her medications. TA's symptoms are probably not part of normal aging. TA's symptoms are not mild cognitive impairment, and it's important to ask TA's husband why he is bringing TA to see you now. So let's just talk a little bit about the difference between Alzheimer's disease and typical age-related changes. So in Alzheimer's disease, you'll see that oftentimes patients exhibit poor judgment and decision-making, the inability to manage a budget, losing track of date or the season, difficulty having a conversation, and misplacing things and being unable to retrace steps to find them, versus typical age-related symptoms, which are making a bad decision once in a while, misplacing a monthly payment, forgetting which day it is and remembering it later, sometimes forgetting which word to use, or losing things from time to time.
So Marianne just reviewed the differences between normal aging and what we might see in a disease like Alzheimer's disease. And so I'll review what mild cognitive impairment means and how that might differ also from Alzheimer's disease. So mild cognitive impairment implies that there's been an intra-individual change. So something's different in the cognitive abilities of the patient. And that difference can come from the patient themselves, from a reliable informant, someone who knows the patient well, or the clinician has clearly noted that there's a change in someone's cognitive ability. In addition to that, on an objective measure, you should see that there's an impairment in at least one cognitive domain. So there are several different types of mild cognitive impairment, with the amnestic variant, or the variant that primarily affects memory, being more likely to suggest that that mild cognitive impairment may go on to progress to Alzheimer's disease. So in addition to the fact that you know that there's an objective change in the person, both on testing and subjectively, yet that change should not interfere with the individual's function. So people may be less efficient in their function, they may need slightly more assistance, but there should be no true functional interference. And so this slide helps to designate what might be different in your evaluation of someone with mild cognitive impairment compared to Alzheimer's disease. And so we'll talk more as this presentation progresses about the screening markers such as the 88, the Mini-Cog, or the MOCA. And so you can see here that in both disorders you would expect normal physical exam, a normal laboratory workup, and again that function piece really helps delineate between the two. So instrumental ADLs should be normal in mild cognitive impairment, as with activities of daily living that may or may not be impaired in Alzheimer's disease.
So let's talk a little bit about what questions we should ask this patient's family. So in terms of querying the informant or family, we have to discuss the history because it is important in terms of a component of evaluation, and also how long the patient has had the symptoms and what symptoms were first present. Anything in terms of new medical or surgical history, any new medication changes, any falls recently, has there been any depression that has been obvious, any language, behavior, sleep, or movement changes, and from the evaluation of the caregiver, how disruptive are the symptoms to the patient and family, and what support systems are in place, if any. And so it's very important to make sure that we ask the informant all these questions because they would provide a rather good history for us.
So this is Maddie. Before we go on to the case, Yael or Marianne, I think the message of this first part that we've been presenting is that when somebody comes in with the kind of symptoms that TA has, the first set of thinking in your decision making as a primary care provider are, and these are, by the way, the questions the patient and the family will have. Is this just normal aging, or is there really something going on with the patient? And the second set of questions really for yourself to think through, at least to begin to think through, because you don't have the full evaluation yet, are these symptoms that the patient's exhibiting, that TA is exhibiting, similar to what you would see in a mild cognitive impairment, or can you say to yourself it's unlikely to be mild cognitive impairment? Yael or Marianne, you want to add anything to that?
Right, so I think when you see a patient for the first time, what you're looking for is this, first of all, is this an acute problem or is this a chronic problem? So is this, you want to sort of think, well, what were some of the very earliest signs that you've noticed in the patient, and how far back could we really go? Are we talking about this person was fine 3 weeks ago and now all of a sudden they're much worse? Or if we think 3 years back, maybe there was some subtle changes in memory, but it's progressing over time. And then you want to look at function. So as Mavi mentioned, is this MCI or is this Alzheimer's disease? So someone may have the memory impairment, they may be repeating themselves, they may have subtle difficulty, but yet they should be able to carry out all aspects of their both instrumental and daily activities.
And actually, this is Marion as well. Yael brought up a very good point, which is trying to find out if there is an underlying reason for the way the patient is presenting regarding the onset. If it's something that is abrupt, versus something that was rather mild in origin, that would sort of delineate whether it's something that perhaps is related to a medication, a fall, any kind of underlying other medical diagnosis. And so it's important to rule those things out first, just to make sure that we can perhaps modify the patient's regimen, for example, if it's a medication, to help them restore their cognitive function.
Okay, so with that in mind, let's continue with the case study. In the past 2 months, this is information you get as a primary care provider, TA is often disoriented and unaware of the date. She tries to look for her parents who are deceased and has mistaken her husband for her son. She has started to wander around the house at night. There's a definite decline from TA's prior level of functioning. She can do simple chores, but she's unable to cook on her own and has trouble operating the appliances. And she needs some prompting for her personal hygiene, doesn't like to bathe anymore. TA reports herself that she's in the office because her husband brought her and denies any problems with her memory. She reports having only recently retired as a teacher. But TA's husband appears reluctant to make eye contact and doesn't appear comfortable describing the changes occurring in his wife. In private, however, he admits that his son has expressed concern last year, but he didn't bring her in for a full evaluation until she started wandering. On physical exam, TA's vital signs, her cardiovascular, her pulmonary, and her neurological exam are normal.
Thank you, Maddie. So these are, this is Marianne. These are some considerations for the primary care provider in trying to delineate what's going on with TA. So first we have to look at TA's history in terms of whether it suggests that she may have an underlying AD. The combination of physical symptoms and history is important to start to rule out other potential causes of TA's cognitive impairment, which is what we just chatted about a little bit earlier. We want to make sure that we're not overlooking something that potentially can be reversed or sort of the arrow would sort of point in the direction other than underlying dementia. The wandering may be the reason for today's visit. For example, the safety of the patient and the husband's health is also something that we should consider. Important to assess for caregiver burden, as we had mentioned before, and provide resources, and there are many resources out there too, just to name some, are the Safe Return Program and the Alzheimer's Association, which has lots of resources available for caregivers.
So I'll move on a little bit to talk about the preclinical and clinical phases of dementia. So as you can see in this chart, what we're really looking at is in fact the pathologic underpinnings of diseases like Alzheimer's disease can occur years, if not decades, before there's clinical symptoms of a cognitive impairment. And so the pathologic process includes plaques and neurofibrillary tangles. The true sort of biology is a little bit under debate, but the idea here is that there is a preclinical phase of Alzheimer's disease in which you have the pathology present, but no cognitive impairment, and then you progress so that the patient exhibits cognitive impairment. This may be more in the mild cognitive impairment phase before there's functional loss, and then you make a diagnosis when that cognitive impairment results in functional loss.
So this is Marian. Let's talk a little bit about the symptoms that often do trigger a visit to the primary care provider. And there oftentimes are issues with safety impairments, such as wandering, driving accidents, leaving the stove on, just to name a few. And the possible early warning signs of preclinical dementia include increased frequency of patients' visits to primary care provider up to 5 years prior to the diagnosis, so that should sort of be a red flag in retrospect. Accelerated weight loss, depression in later life, physical frailty, and gait disturbances. And just to go back to the accelerated weight loss just for a moment, it's oftentimes unexplained weight loss. It's not intentional weight loss, and so it's an important fact to delineate. And you can find these and other warning signs at the URL address listed below.
So let's talk a little bit about the physical exam. So as we said before, generally in Alzheimer's disease, the physical exam is normal. And so if it's not normal, that would help to sort of guide your clinical decision making about what other things you might be looking for. And so what's not listed on this slide that's also important to assess is vision and hearing loss, which can certainly play a role in cognitive impairment. And so some physical exam findings that you might see that would make you think about a different differential diagnosis would include Parkinson-like features. This would include bradykinesia or slowed movement, stiffness or rigidity, balance problems, which is postural instability or resting tremor. If you see focal neurologic deficits on exam, that might guide you to think about cerebrovascular disease or other vascular risk factors. Abnormalities in gait would again make you suspect either vascular change. And then if there's this triad of a dementia, a gait apraxia, and urinary dysfunction, then you might want to consider something such as normal pressure hydrocephalus. So this slide helps to look at the difference between vascular dementia and Alzheimer's disease. And in fact, the new terminology of how we think about vascular dementia is this terminology of vascular cognitive impairment, which is really a spectrum. And if you think about that spectrum of vascular cognitive impairment, you would see mild changes. And at the far later end of the spectrum would be what is considered to be vascular dementia. And so the difference here is on imaging, you would see vascular deficits. You may see change in the physical exam, how we discussed before. And the idea with vascular dementia is that you may see a different progression or more of a stepwise approach.
So this is Marianne. Let's talk a little bit about, based upon the case study that we've been reviewing, the objective findings that you may find on assessment. So TA scores 10 out of 30 on the Montreal Cognitive Assessment. Her ability to write a clock is impaired. She names 5 animals in 1 minute, and her husband completes the AD8, and the total score that he gets is 6. And we can talk a little bit in greater detail about what these findings suggest. So considerations for the primary care provider in terms of the workup. So the performance, we have to look at the Mini-Cog and the MOCA, the Montreal Cognitive Assessment. And the Informant, as we had mentioned before, in this particular instance, he got, I think it was a 6. So the AD8 is important to discuss regarding the Informant's score. There are several screening options that exist depending on the clinical preference and the patient population with whom we're working. Signs and symptoms need to be consistent to make, signs and symptoms are consistent with the need to make a referral and with the diagnosis of AD. And we need to assess function and behavior as we had mentioned before. So the Mini-Cog, you can actually find this later on in this presentation. We'll talk about the websites that you can find this on. But this is the Mini-Cog, just to name some of the Try This series that are available on the Hartford Institute for Geriatric Nursing, and these are some objective scores that can try to delineate further whether this is an underlying memory impairment or something else. And then this is the AD8, which we mentioned before. This is the Washington University Dementia Screening Test. This is also available on the Try This series on the Hartford Institute's website. And this is the MOCA, which we mentioned before, the Montreal Cognitive Assessment as well. And this is also on the Try This series.
So,
before you start this, can you say something about using these tests in primary care practice, how skilled the provider needs to be, how long these tests would take?
Right, so the Mini-Cog is a very short screening test which would involve a 3-word recall in addition to your clock. And so what's nice about the Mini-Cog is how quick it is, but it often misses people with milder impairments. And so the Montreal Cognitive Assessment is really a very helpful screening tool because it really assesses for a lot of different areas of cognitive function. In addition to that, if you want to do serial measurements of a patient, there's several different versions in English, and there's a blind version. So if someone's visually impaired, then that would allow you to be able to assess the patient. What I will say about the Montreal Cognitive Assessment is that it is very helpful to look at the instructions on the website because it does involve some knowledge about the test to make sure you're scoring properly, especially based on education. And so essentially there are tons of screening tools out there, and so we're not advocating for one over another, but what we're saying is here are some examples, and as the primary provider, you should get comfortable with a few and then use those to help to guide your decision making. And what's nice about the AD8 is that in addition to just objective performance of the patient, here is your ability to really get a sense from the informant whether there's change in the patient. So you're really only comparing the patient to themselves. So I can't reinforce that enough, which is that you really need to think about how is this person different now compared to how they've always been. And the 88 helps to pick that up. And you can do it in your waiting room. So you can even have someone do it before you actually see the patient.
And actually, Yale brings up a really great point, and something that is important not to overlook is that serial measurements are very important to delineate further if there is objective decline. And so it's important to sort of find if the patient has become stable on a particular regimen versus if they continue having cognitive decline. And so serial measurements are very important. I'm glad you brought that up, Yale.
Right, and because the mini mental state exam was used for so long, often patients, by the time they get to me, they'll sit down in my office and say apple, table, penny. They already sort of know the questions that will be asked, so it's nice to kind of use a little bit different word recall and the like. So for the clock drawing, so what's nice about the clock is it's really included on most screening measures. So it's included on the Montreal Cognitive Assessment as well as the Mini-Cog. And what's important here is that you should never give someone the paper that has the circle pre-drawn. You should always, part of the evaluation is having them draw the circle. You're looking for the numbers to be in the appropriate quadrant and the hands to show the correct time. So commonly on the clock drawing test is to ask the patient to draw the time 10 past 11. So this slide is the DSM criteria for Alzheimer's disease, and so briefly I'll just say that essentially the diagnosis is made based on number one, an impairment in memory with one or more other cognitive impairments, whether that's aphasia, praxeagnosia, or disturbance in executive function. And as we said, the cognitive deficits need to be sufficient to interfere with function, not explained by any other psychiatric or medical illness, and have a gradual onset. And so while the DSM-4 is nice to review now, we may not be using the term dementia in the future, so the DSM-5 actually has changed the terminology so that these disorders in mild cognitive impairment will be called mild neurocognitive disorder and major neurocognitive disorder. So you might see major neurocognitive disorder due to Alzheimer's disease, due to Lewy bodies, due to frontal temporal dementia, and the like. And so here's just an example of an algorithm that you can use for the diagnosis, management, and assessment of Alzheimer's disease in primary care. And so what's nice about this algorithm is that you can follow the algorithm in whatever step you're comfortable with. So for example, if you're comfortable doing the initial evaluation and the screening but not the workup, then you can decide if you want to complete the whole algorithm or if at a certain point you think a specialist referral is necessary. So when might a specialist referral be necessary? So this is really at your own judgment, but generally if someone has a more atypical presentation or you're uncertain, Alzheimer's disease can present with different variants, whether it's a visual spatial variant or a language variant, that might be unusual. If things are progressive rapidly, if there's significant comorbidities of psychiatric disorders or really difficult to manage behavior, personality change, language, and especially if someone's really interested in research participation or clinical trials, then a specialty office might be able to better review those types of services.
Okay, yeah, we're going to move into sort of management, and we haven't spoken about all of the imaging options that are available, which there's an enormous amount of literature about, which you as a primary care provider listening to this module must be asking yourselves, why are they not ordering any imaging? And I think now with patients being and families being able to access the internet and look up workups, they'll see mention of some of the imaging. Do you want to say something about why we're not talking about imaging here?
Right, so by and large, if someone's never had a brain image, whether it's a CAT scan or an MRI, there are some different recommendations from the different academies, but generally, at least in specialty practice, we do at least one initial image because you can't always see everything, and so you want to make sure there's no tumor, bleeding, you're not missing anything on the exam. But then I think what you're really getting at, Maddie, is biomarkers. And
Correct.
so when we think about what's available, there are several different biomarkers. And so to name a few, there's the new amyloid imaging. There are FDG PET images, which look at glucose metabolism. And so in a specialty office, we generally think about using biomarkers only in certain scenarios in which, after you've really done the thorough history, you've done the initial rule out of imaging, a physical exam, etc., then you might want to consider, for example, an FDG PET image if you're unsure very specifically about whether this is a frontal temporal degeneration or Alzheimer's disease. And so that's really the indication that Medicare covers an FDG PET image for. So that's for a specific patient. And then the amyloid imaging, the challenge here is that if you have a positive amyloid test, that's not a way that you make a diagnosis. And so for most people, a diagnosis can be made with a pretty high degree of accuracy, again, by this comprehensive history, by the full medical workup. And so the percentage of accuracy that you're adding by doing biomarkers is not sufficient to really warrant it, not to mention the additional cost. And so the last thing that I think is important to mention is you have to ask yourself, will this change treatment? So if you think that the person has Alzheimer's disease and you do an amyloid scan, if you're already treating them, there's no treatment at this time for the preclinical stage or for any disease-modifying therapies. And so again, if it's not going to change treatment, then we tend not to do the additional tests.
So your recommendation for a primary care provider is?
My recommendation would be to do at least one image, whether it's MRI or CAT scan, again, to rule out any concurrent pathology that you can't see. And then I would consider probably specialty referral for biomarkers, just to really know more about how to interpret those findings and to allow their own review of the findings, because sometimes it gets tricky if Amyvid PET scan shows one thing, but the FDG PET shows something else, and then a lumbar puncture shows something else. And then there's the whole other question when primary care providers start doing the genetic testing without really true understanding of the implications of that. So I think for right now, the recommendation would be to do one image and another if in the future there's some change in physical exam, to be concerned about vascular disease or some other change.
So because we are going to have many people, I think, in primary care settings where referral to a specialist, such as you have at the Langone Medical Center, is really not possible. So can a primary care provider feel comfortable if they've done all of the workup that you've described and the one imaging, if the patient hasn't had it in the past, that they can go ahead and make a presumptive diagnosis of Alzheimer's disease?
Right. So I think that if the patient's a pretty typical patient and presents in, the presentation that we've described, then I do think it's possible. I think if someone is atypical or they're not progressing in the way that you would expect, or there's something unusual, then additional biomarkers may be warranted.
Terrific. Okay, great. So let's then continue with the case study. So in the situation that we're describing, which we say is a typical presentation of somebody presenting with dementia, with Alzheimer's disease, we are then talking about the primary care provider beginning the additional workup and also beginning some intervention, so some management of the patient, of TA. And so this would be the next step. So TA is started on donepezil. I can never pronounce it. Right, with a gold dose of 10 milligrams a day. She is referred, as Yael was talking about, for an evaluation and a CT scan of the brain. And then, as a primary care provider, what we would hope you would be able to begin to do is to take a multi- or interdisciplinary approach to address close follow-up of her cognition, her function, and her behavior by utilizing support from a nurse practitioner and a social worker, and also to begin to make really strong referrals for TA's family, her husband and her son, so that they're both informed about her diagnosis and the potential progression of her disease. And we are suggesting that the best first referral, at least, would be to the Alzheimer's Association. And the Alzheimer's Association has chapters in many different communities, and they have a really excellent website so that the family can find information about both dementia and Alzheimer's disease, but also information that you will want to think through, help the family think through in terms of financial considerations, future needs for health care, potential placement, support groups for both the patient and the family, and those kinds of things. And your best source of referral for all of that for the family is the Alzheimer's Association.
Thank you, Maddie. This is Marianne. We're going to talk a little bit about the goals of care for patients that have dementia, and you'll find as we discuss them that they're really not unlike the goals of care for really anybody else. And so people with dementia are individuals, obviously, and they have the same needs as all of us. They also have the same values as other adults. They can be happy and healthy, and small changes have great practical value. And let me just stop by saying that that's both positive and negative. And so even if you were to sort of mitigate something that can be perceived as something, a small negative sequelae, that can actually end up being a very positive change for the patient. And so it's important to address even the things that could be considered sort of minor. And it's also important to say that something always can be done to help. And that's both practical, that is true, and also to give hope to the family and the patient that we can always do something to help. And as we had just mentioned, even small changes really add a lot of positive value. And then the 4 pillars of dementia care, it's important to treat the disease and the symptoms and support the patient, but also we would be overlooking a huge segment of the population if we were to say to not support the caregiver, because they really need a lot of support. And we had mentioned some services that they can get. Important to always focus on the caregiver as well, because as the patient progresses, the caregiver likely is going to need a lot more support, and so it's important to talk about that as well.
So let's kind of shift back to the management piece here. And so when we talk about medicines for Alzheimer's disease, there are 2 classes. So in one class, the cholinesterase inhibitors, you'll see there's actually 4: tacrine, A receptor, donepezil, which is generic, galantamine, and Exelon or rivastigmine. So tacrine's not generally used due to side effects, and so of these 3, they have similar efficacy, and the way they work is to prevent the breakdown of acetylcholine. And so I think the education piece for patients and caregivers is really important here, because these are symptomatic medicines. And so when you prescribe these medicines, I think it's important that you review with patients and caregivers kind of their expectations. And so our philosophy is that when people, by and large, as a group, are followed over time, that people tend to do better with the medicines, assuming they can tolerate them, than without. And so patients and families shouldn't expect that when they take these medicines, suddenly they'll remember, to take their medicines and have improved memory. But the idea is that these medicines can help modulate behavior and have other positive benefits. And in clinical trials, there was some small improvement in activities of daily living and in cognition. And so the decision in terms of which to use depends on disease stage, side effects, cost, etc. And then Namenda stands alone, and so Namenda helps to regulate the activity of glutamate. And so the sort of theoretical concept is that it's an NMDA receptor antagonist, and it potentially is neuroprotective in a way. And so in clinical trials, it's shown to have a small improvement in cognition and sort of the global assessment of dementia, but it's really approved for the moderate to severe stage of Alzheimer's disease.
Yael, do you want to say something about when you would know that you wanted to discontinue a medication?
Yeah, so it's a good question. So in practice, we tend to continue medicines as long as we think that they're having some benefit, and so we tend not to stop them unless someone is at the end of life and is essentially declined to the point where you don't think there's much places for the medicine to be active. But I think to go back to the education piece also is that people still get worse over time, even with the medicines. And so I think it's that education piece where you would still describe that there are places for the medicine to work, but the brain still degenerates. And so I think that there is still a role for medicine until you don't think that there's kind of added value.
Okay. Marianne, you want to add anything to that?
Yeah, I think that it's great that you bring up that point, Yale, because I think it's important for family members and caregivers to understand that there still can be a positive effect from the medication being prescribed, even in the setting of some hopefully mild cognitive decline. And so I think it's important that you brought that up.
Great. Sorry, Yael, I disrupted your thinking here.
No problem. Okay, so we'll move along to what we had previously mentioned, which is this collaborative approach to care. And so the reason why this is important is because we know that the early recognition of cognitive impairment does improve outcomes, but yet here we are in primary care where when we're talking about doing a really comprehensive evaluation of memory and thinking, it takes time and it takes ongoing follow-up, and especially in the setting of dealing with all other chronic medical diseases, this, again, you sort of, it's hard to just do it on your own, right? And so, as Maddie mentioned, a specialty memory center may not be available or feasible for every patient. And so utilizing this multidisciplinary approach really makes sure that both the family and the caregiver are getting access to everything that they need. And so when we think about what a collaborative approach might look like, so again, this is not a model in which you either have a nurse practitioner or physician's assistant or a physician who's doing all of the evaluation, management, and treatment. And so you're really utilizing additional support. So whether you have a nurse in the office that can help with some of the cognitive testing or the referral piece. And I think the physical, occupational therapy, and social worker component to this are incredibly important. And not every office is going to have something on site, but just to know about what referrals are available in the community and to have a really solid referral source and is again incredibly important to both making sure the patient and the caregiver's outcomes are as good as they can be. And Marianne will talk a little bit more about how some of that referral might work.
Thank you, Yael. Yes, the collaborative approach to care is very, very important for patients such as TA. All members of the team should share the burden of referral for concrete services. And as we had mentioned just briefly, the multidisciplinary approach to care is really, really important because each specialist brings something unique and important to the table. So it's important to the extent that you can, get a multidisciplinary team on board. Learning disease-specific websites and support groups that as we had mentioned before is also very important because the more you know, the more empowered you are. Get to know common local referral sources such as physical and occupational therapy to help with movement and to decrease the risk of safety impairments, driving evaluation centers, options for cognitive remediation, behavioral health programs, geriatric care management services, and high-quality direct care agencies.
And Marianne, before you go on, I just want to emphasize that how important it is to really get to know your local referral services. In participating in support groups for Alzheimer's disease family members, which I did for many months, the kinds of questions they have are not necessarily ones you're going to be able to answer. Where do I find a caregiver who can come in 3 or 4 hours a day, who's really tuned in to the needs of a patient with dementia? How do I find a dentist who can deal with my family member who has dementia? Where are they good physical and occupational therapy sites in your community, again, that are comfortable dealing with somebody like TA, who isn't necessarily going to take the normal approach to a PT or OT? And bringing in somebody, the repository for much of that information is your local Alzheimer's Disease Association. So bringing in somebody to the office who can talk to you and act as a partner to you as you set up your collaborative approach, reiterating what Yael said, which is that you don't need to have everything in the office, but you need to create a virtual office for this person where you're making not just casual referrals or go find PT, but you're really saying to them, we work with this place and they are very good around issues of somebody like TA who may wander or not pay attention. And I wondered if Yael or Marianne wanted to add anything to that.
Yeah, and so the reason why this says to sort of share the burden of concrete services is because, as Maddie said, this alone is what patients and caregivers really need, yet these services are not billable and they take time. And that's why if we talk just purely practical, it's not always practical that not only are you diagnosing, managing, and treating, but then you're going to refer. So this is where, again, utilizing all aspects of your whomever's in your office or whomever's not in your office to make sure that you're referring to the things that caregivers really, truly need.
And I think also Maddie brought up a really good point, which is to see if we can leverage community services in the home, because these patients already have some degree of cognitive impairment, and the home is a place that is familiar to them, so they can sort of look around and oftentimes self-orient to their own environment. And when you bring that patient out of their home environment back into an office practice or an acute care setting, that alone can cause a lot of disorientation to the patient. So I think leveraging home care and community services really can help, even separate from any intervention that we can do to continue to stimulate the patient in a comfortable environment.
Terrific. Okay, Marianne.
Let's talk a little bit about, these are just some resources that you can use for primary care providers. There's a great dementia overview at the Hartford Institute e-learning center, and you need to register to get on there, but that's the URL address for the Hartford Institute. There's also a URL address for the mild cognitive impairment and Alzheimer's disease, and you can access that via the Hartford website as well. Collaboration is very important, as we had mentioned before, and so taking collaborative approaches to memory disorders is something that really is pivotal for patients such as TA, and you can find their address there as well. And as we had mentioned, the Try This series also has a lot of really good resources, and Consult Geri RN is the URL address that you see here as well.
Here at the Hartford Institute, we've developed 4 fact sheets which we think might be very helpful as resources for patients and for family. These fact sheets are online at this URL. You're welcome to download them and give them to patients. You're also, and family members and other informants that come in with the patient. And you're also welcome to put them in your office, to copy them and make them available to patients. They're pretty much one-page fact sheets. The first one is about commonly asked questions about Alzheimer's disease. The second one focuses primarily on mild cognitive impairment. The third one is really commonly asked questions once a patient has been diagnosed as having Alzheimer's disease. These are the kinds of questions family might ask about where I get financial information, where I can get help with managing somebody at home, what do I need to think about advanced directives. And all of these on the fact sheets, you have information about each of these topics and then a good referral source. Many of the referral sources online. And then the 4th fact sheets are commonly asked questions by family members when the patient has advanced dementia or Alzheimer's disease. And I mention these fact sheets because if you go and just Google Alzheimer's disease, there's a huge amount of information both for the primary care provider and then obviously for anybody, patients and family members. And it's very hard to sift out what is authoritative and evidence-based information and what is not authoritative evidence-based. The fact sheets don't have everything by any means, but everything on the fact sheets are evidence-based so that you can give them out to patients and family members with some confidence that they might be useful to them.
So Maddie, we're going to switch gears just a little bit to talk about referral for hospice. Now obviously, in this case that we have been discussing through the last couple of, 40 minutes or so, this patient is a long way from needing hospice, but it is something that is important and should be considered. So first of all, there is objective criteria that exist for people that have Alzheimer's, and also it oftentimes is based upon the objective score of the FAST, which is a functional assessment staging. And so that can oftentimes guide primary care providers regarding how functional this patient is and whether or not hospice is an appropriate consideration at that juncture. Hospice eligibility involves both the patient's cognitive and physical medical status. And the options should be discussed with the family when the patient has less than 6 months to live. But that's obviously a very, very hard thing to anticipate. And so hospice referrals really are appropriate when you want to increase the comfort measures and focus really on the quality of life for patients that have Alzheimer's disease or really any other underlying medical or a cognitive impairment. And then, as you can see here, this is just a graph depicting the mini mental exam score and how its decline over the years. This is over the course of close to a decade. Its decline begins with cognitive symptoms, and then the patient, and that's in the early stage. And then, as we approach the mild to moderate stage, the patient begins to lose their function in terms of the activities of daily living. And then in about the 3.5 to 6 year juncture, patients oftentimes begin to have behavioral problems. And then oftentimes in the moderate to mild or the mild to moderate stage, nursing home placement is something that could be a consideration. And then as you can see at the bottom, death is somewhere, it obviously has a long trajectory, 3 to 9 years could be as long as it could take based upon this graph for patients that have Alzheimer's disease. Progress to death could be over the course of a decade, as Yale had said earlier in this presentation. And so this sort of goes back to the hospice discussion that we just had earlier to try to leverage the quality of life that patients have by focusing on making patients comfortable and small changes can really be something that could be significant really at any stage in this particular progression.
So this slide just discusses the functional assessment staging scale, which more information can be found on the link below, but essentially it works its way through 7 stages. And so when we talk about hospice criteria, we're really concerned about stage 7, or the severe dementia stage. And so more specifically, hospice is met when someone is at the stage 7C or later. And so essentially at this point, when the disease has progressed to the point where someone has trouble walking without personal assistance, and then ultimately their ability to sit up is lost, and the disease progresses.
Thank you, Yale. And these are some objective criteria that you might see for admission to hospice of patients with dementia due to Alzheimer's disease or related disorders. And so if the diagnosis is Alzheimer's disease, the eligible patient generally would have one of the following within the past 12 months. Aspiration pneumonia, because the patient could have some difficulty swallowing and as a result can aspirate whatever food or fluid is hoping to get down into the stomach. Pyelonephritis or other upper urinary tract infections. Patient oftentimes at this stage has some degree of urinary incontinence, and so that can end up becoming a pyelonephritis or UTI. Septicemia, decubitus ulcers, multiple, oftentimes stage 3 or 4. A fever, even in the setting of recurrent antibiotics. Inability to maintain sufficient fluid or calorie intake with a 10% weight loss, of course unintentional, during the previous 6 months. Or a serum albumin level less than 2.5, which is suggestive of an underlying malnourished state.
So let's leave this slide up for a minute. I think we're trying to make a couple of points here about hospice. One is, if you're not aware of it as a primary care provider, we're saying to you there are objective criteria that a person can meet to be eligible for hospice if they have dementia. So if you're more used to seeing somebody referred to hospice with a diagnosis of cancer, for example, we want to sort of alert you to the fact that you can keep in mind that the patient with Alzheimer's disease will reach potentially a stage where they would be eligible for hospice benefits. And those hospice benefits can be delivered at home, and they can be delivered in nursing homes. And there are many nursing home residents with advanced dementia and some of the comorbidities that Marianne has mentioned who become eligible for hospice and receive hospice care in the nursing home. So it's as you begin to think about encompassing patients with dementia in your practice and thinking through a collaborative approach to their care, which is what obviously we're hoping we've indoctrinated you to, keep in mind that there will be a stage where you can begin to discuss with the family their eligibility for hospice. The thing we haven't discussed in this sort of end-of-life perspective is also the possibility that the patient might benefit from palliative care services. And I think we didn't do that in these slides because we think that there are not many places around the country where there really is a very active and organized structure for delivering palliative care services. But if you live in an area where palliative care is available in either an academic medical center or a local hospital where there is a palliative care team, obviously people with Alzheimer's disease would also benefit from a palliative care approach to their care, and that can come much earlier than when they're available to hospice. So we didn't make a slide about that because we know that some of you in areas where palliative care is really just taking hold, but we don't want you to leave not thinking about that. And I don't know, Yael or Marianne, if you want to add anything to that.
Yeah, I think you made a really good point, which is that palliative care is kind of your you're able to refer to palliative care when someone really needs that symptomatic management, and the goals of care are comfort, but yet you can't say that this person has 6 months or less in a lifespan, which you really need to say in order for them to be eligible for hospice. So it's nice to kind of use that model of care, but I think the challenge is just, when we talk about palliative care, there's more clear-cut referral reasons like pain management and the like, and sometimes with dementia, the times when you need it are more for severe behavior, weight loss, things that it's a little bit more difficult to use palliative care for, but I think in a perfect world, there's a great need for it.
Right, and I think that what I really appreciate about the slide is, as a primary care provider, I like that there are objective sort of, an objective guide for me to say, okay, let me at least start thinking about hospice care because this patient has had, let's say, for example, 2 episodes of septicemia in the last 12 months, which is, of course, suggestive of the patient becoming much more weakened. And that's really the overarching theme in these medical diagnoses, is that the patient has difficulty swallowing, has difficulty managing urine output, has difficulty moving. And so that's the reason why these medical diagnoses are suggestive of advanced Alzheimer's disease, because the patient has become weaker and is having difficulty managing all the ADLs and their output and their ability to take things in a proper fashion so it doesn't become an aspiration pneumonia. So I like that this kind of gives you some objective information to guide you, at least towards thinking about it. I think that a lot of primary care providers are kind of hesitant to use the word hospice because that sort of suggests, well, there's nothing more that we can do. But really, hospice is leveraging the things that we can do and really focusing on what can help the patient feel better. And so I think that it should be sort of taken in a positive way rather than something that's a negative.
Terrific. So before we close, Yael or Marianne, anything that you think we haven't covered or that you want to emphasize or takeaway messages for the primary care provider who's listening to this podcast?
So I think we've covered everything, but I think the take-home points would be that when you're evaluating a patient, that number one, part of the evaluation, I really think as much as possible should also include speaking with a reliable informant. So it's just so helpful to get that piece of the history based off of someone who really knows the patient well, because there can be a lack of insight in the patient, and you as the provider, you might see that maybe they're missing appointments and maybe they don't recall all the conversations that you've had with them, but true history and evaluation, I think, does include a reliable informant. And I think if you sit down with the patient and you really do a thorough history, and then you use the physical and the neurologic exam to help to guide you, I think when you sort of put all the pieces together, that in addition to the objective screening measures that we talk about, can really help to guide your practice in terms of making these, what can be sort of a complicated diagnosis.
Thank you, Yael. And one thing that I just wanted to underscore is really caring for the caregiver, because I think that although we had mentioned that before and we'd given you some great resources, I think that as primary care providers, sometimes we're so focused on the patient that is seated in our waiting area that we sort of forget about everybody around them, those that are helping to support them. And so I really would like us to focus not just on the patient in the true sense, but really everybody that's helping to support this patient, because it really does take sort of a team approach, both in terms of the professionals on the team and the caregivers that are home with the patient. It really can deteriorate the relationships of those in the family, and so helping to leverage community resources can really help to sort of remove some of that burden. So I'd like to just sort of focus on that a little bit as well.
And I guess my takeaway message is that if this is something that you really want to improve your primary care practice and you want to do one thing on Monday morning, I would get a hold of the AD8 and I would put it in your waiting room, and I would have every patient and family member that comes into the waiting room answer the AD8, because that will give you the very first clue, very easily collected. The patient and the family are their own respondents as to whether there's some early changes that you might want to focus on. So if you want something to do on Monday morning around setting up your primary care practice so that it's responsive to the care of people with dementia and their family members, that's my suggestion. So thank you very much for listening to and completing this module. Just to reiterate, this is an online module of the Hartford Institute and the CNYGEC. And here are the websites where you can find this module and a lot of other resources that we think will be helpful to you as a primary care provider. Thank you very much.